Thank you, Mark. I'm going to go easy on soccer punts. I was just thinking that I'm not going to put this on you. So thanks everybody for having us here. I was mentioning this yesterday. This is kind of our best Philly location so far. Yeah, it's the air quality, of course, is a different matter, but it's really nice having everybody here. And this is like one of my favorite talks every year that I can talk to you guys. So clinical update for STXBP1. I've done this as a bit of like a template that is like always the same every year, and I'm trying to add in a few things that are new. And this is meant for some of our new families who kind of would like to hear this for the first time, and of course for those of you who have already kind of heard about this. So we think about clinical and natural history and natural history studies, most broadly as an idea of making STXBP1 predictable. You know? And we have this like growing knowledge. I'm going to talk about our natural history study. You'll kind of hear Kristen and Anna give a bit more detail on this afterwards. I'll tell you about STXBP1 and seizures. There were some very good questions yesterday already on how important this actually is, and I'm going to show you what this looks like in real life. And then some of the things we've learned about STXBP1 development. So let me get started. First of all, I just wanted to point out again that we started with trials last year, and what we learned as a community is that trials have potential but also danger. Yeah? So we all know that we had the capsular trial and that the first participant in this trial passed away. Yeah? And we just felt as like the star investigators just to point out that this is part of our shared history. Yeah? So this is kind of something that we've seen, and that was a very sad event. What we've also seen is that what it really means if a community kind of stands up and pulls people through this. Yeah? Just from like our side as the clinicians and the trialists, this was an immense support we got from the family with very encouraging words afterwards, and of course also from many of you. And some families even said, yes, we would have made the same decision. So this is a thank you from us as the investigators. And I think people have just realized this internationally, how strong we are as an STX community. So STXBP1, and I think British, you kind of mentioned this. It's named after the gene, yeah, and it's a mouthful. Yes, so it's the STX or the syntaxin binding protein 1, and what I'm showing here is where STXBP1 lives. So on the top left, you have a nerve cell, this is a neuron. And then we're zooming into the part which is called the synapse, where one nerve cell talks to the other. And STXBP1, you can see this at the top right. Oh, this is actually a laser pointer. Ooh, nice. So STXBP1 sits here and makes it possible that nerve cells, that neurons can communicate. Yeah, it's a very important point, and it has this little bean shape that you're going to see here. Yeah. And so this is important for making all the other parts work. So it's the master regulator of what is called synaptic vesicle fusion. STXBP1 is new but fast. So this is a timeline that we've just seen on how fast STXBP1 and knowledge on STXBP1 emerged. Yeah? So it was first found in mice, and then it was found in humans as a disease-causing gene, and somewhat in the early 2000s. And now we're looking at more than 500 people where we have good data on. And of course, you've seen the data from Charlene, how many STXs we have worldwide. We started out thinking about what do we actually want to treat by doing a so-called disease concept model. And this sounds like a very technical term, but it is basically a description of what families experience as the burden of STXBP1. And what you can see, we have symptoms, we have symptom impact, and we have impact on caregivers. Yeah? And what you see here, these three different kind of colors, is how STXBP1 changes over time. Very, very early on, we have lots of concerns about development, and seizures. This is then often replaced by concerns about behavior. Yeah? So those are these things where we try to understand how can we measure this, so we know that therapies are effective. This is now data from more than 500 people with STXBP1, where we try to understand what is the what does this look like in a patient? What does it look like in our STXers? Yeah? So we know we have developmental delay, hypotonia, speech impairment, seizures. And the little plot in the middle is called a radar plot. And this is an idea on how you can present how common features are in people with STXBP1. So I'm part of END, and END is our kind of Center for STXBP1 at Children's Hospital of Philadelphia. I'm going to show you this slide to give an idea that there are actually many groups working on this. So Dr. McKee and I were in charge of the clinical team. Sarah, who you've kind of heard mentioned already, is our lead genetic counselor, talks to every newly diagnosed family in the US. Dr. Prosser is our director who's interested in kind of disease-modifying therapies. And later on today, you hear from Beth Davidson about gene therapy. So this is our entire firepower that we have in END. When we think about natural history studies and STAR, those are studies that are meant to eventually be used as comparators, as controls for trials. And what I tell all of you guys when I see you in clinic is that with every single data point we get in STAR, we make it more likely that we can avoid giving placebo to an STXer. This is our goal. We have a very strictly controlled natural history study that is run as if this was a clinical trial to make sure that we can have comparison data once we have two compounds and two medications to get ready. So when Charlene showed you this picture of 17 therapies, they need something to compare them to. And this is what STAR is doing. Kind of getting here my applause and comments from our STXs. So STAR is a national study. So we've worked very, very intensely with everybody involved over the last few years to have a national network of centers that are centers of excellence. And we have 6 sites for STAR to make sure that wherever you live in the US, you are somewhat relatively accessible for a STAR site. And Mark already mentioned that STAR has been growing tremendously. Yeah, those are the numbers here. And just to explain the plot on the very left, this starts in July 2023. This was our kickoff. Sorry, this was my only soccer pun. Yeah. Going through July this year. And right now we've had 183 STXs we've assessed once. And then the other lines, you can see how many of them came back. One thing I want to kind of point out is that we're at the midpoint now. So what we really have to make sure right now is that we keep on going, that we don't take the foot off the gas pedal, because we need data, so-called longitudinal data. We need to show data over time. And I'm going to explain this to you in a minute. But here is the number. We're doing some very interesting things in addition to the clinical assessments. This is a little cartoon for a so-called tremor assessments. So we have sensors that we put around arms and wrists of our STXs, and we measure the STX tremor. Many of you kind of know this kind of very strange tremor that we often see when our kids are waking up or when they have a fever, and we're trying to measure this with so-called wearable devices. And we're doing EEGs. So we have a research EEG, and you can see this on the left. This is like a net. It's not like the EEG where it's been glued on, but it's very, very quick to put on and to take off. And this helps us to assess brainwaves. This helps us to understand what are these so-called spectral features. If you take an EEG and all these squiggly lines, there are frequencies behind this, and we can use this to understand how severe STXBP1 is. And we've made some very good progress there. So what have we learned about seizures in STXBP1? And this is one part where many of our families know this much better than most biopharma partners or most clinicians, because what we know is how unpredictable seizures in STXBP1 are. I'm not trying to say bad or mild. I'm using the word unpredictable, because we know, in contrast to other conditions, seizures in STXBP1 tend to fluctuate a lot. This is one kind of way how we looked at this a few years ago. Here is now an update on how seizures in STXBP1 look in 2026. So this is data taken from 107 STXers. When we add this all together, we have 903 patient years. And what we did is that we measured and counted seizures for every single month of every STX's life. Yeah? So what we see here is basically the landscape, the broad overview of seizures in STXBP1. We know that so-called focal seizures are the most common seizures. Every fourth STXer has what is called epileptic spasms, yeah? And then tonic seizures are quite common. And when you look at this kind of figure, you see there's 1 at the top, 0 at the bottom. This shows you the percentage, the proportion of STXs at any point in time, so every little bar is a month, of the STXs who have seizures. So if kids have seizures, it's in red. If they don't have seizures, it's in gray. What you can see here, the seizures in STXBP1 are frequent, but they only occur in less than 40%. So if you take an STXer and just randomly select a month of this patient's life, it's actually not very likely that this STXer has seizures. And this is important for us not to say that seizures are nothing to worry about. It just means that this is not good for clinical trial development. So for those who have seizures, we have to be very, very diligent treating them. But when we think about this more broadly, what we don't want to do is give our biopharma partners the wrong impression that they are looking for so-called seizure endpoints. This has been something that has changed quite a bit over the last few years. I also wanted to pull up again this slide that I showed last year. And this is about seizure recurrence in STXBP1. This is something that we talk to families quite a bit in clinic. How likely is it that seizures come back if you have... All right, you guys are very good on special effects. If I were to come up with a pun, I would say, Mark, this house is on fire. Yeah? Let me see whether I can go through this slide without any kind of fireworks or something. So families often ask us, how likely is it? If you had seizures, then we finally are at this point where we have one of our STXs seizure-free. How likely is it that seizures come back? And do they always come back during puberty? Yeah? So we have the benefit, we have the advantage that we can look at the data. You know, we have data on all our STXers. And first of all, the fact or the idea that things get worse during puberty is not true. We hear this in many disease conditions. For STXBP1, this is not true. If seizures come back, they can come back at any point in time. However, if someone with STX is seizure-free for at least 12 months, it only happens in 3 to 4% of all STXers. This is how we can basically measure and give you guys information about how likely things are. It is always very dramatic when we see seizures return. But here we have the broader overview that this is something that is still very, very rare. Yeah? So seizure freedom in STXBP1 is good. It is sustainable. What we're doing right now, and I'm sorry that my slide is a little bit off here, is that we're asking everybody who has an STX with active seizures to come and talk to us later on our table. Tori and Joelyn, I'm going to be at our table afterwards for research, to sign up for the EMMA app. So this is an electronic seizure diary that we're doing jointly with our European partners. This is very important because we want to have a very controlled way how we can document seizures. This tool is very easy, I promise. Yeah, but if you have seizures currently and are being treated for active seizures, please see us because we would like to sign you up for the EMMA app if you're part of STAR. The other thing I wanted to mention is that we're currently doing what is called the STX genome study, where we're asking the question, what is there other than STXBP1 that tells us how severe our patients are? Yeah? Why does one STXer have seizures and the other doesn't? Why do we see infantile spasms and we have the same STXer with the same variant with tonic seizures? Those are things that we're trying to answer going forward. Yeah? And this is when we look at the entire genome. So what have we learned about development? And again, I'm going to go back to my little subline here. We're trying to think about predictable and unpredictable patterns. Yeah? And what I wanted to point out is that both is true. We have some features in our STXers that we are learning to understand very, very well. And there are things that we don't understand well because everybody is different. So when I talk to families in clinic, I always make the difference between what is STX and what is personality. Yeah? And everybody knows what I'm talking about. Yeah? So there are lots of things that are very unique to our STXers, but those are not part of the disease. So this is the data on milestones and how our STXers are kind of move towards walking and move towards milestones when they have them. Bridget, you mentioned this earlier about like what people told us 6 years about none of the STXs are walking. Yeah? It is not true. No, we know now that basically 70–80% of people with STX will achieve independent walking. Yeah? It's not that this has never been true, but this is something that is important to know when we counsel families, when we give them information with a new diagnosis. Yeah, and again, we have many people with STX being diagnosed basically every week, every month, and this is the information we can give the newly diagnosed families. On the right, you can see how many STXs achieve a certain milestone, the ability to vocalize, the ability to kind of use nonverbal communication. Verbal communication in STXBP1 is very challenging. This is one thing that is true, and this is something that we're seeing too. But there's tremendous benefit on working on nonverbal communication, yeah, at kind of assisted communication devices, and this is where communication really is. So communication in STX is more than speech. There's eye contact. Our STXs are very good with this, and this is something that we can really invest in. So I'm going to go a little bit scientific now, because I wanted to show you a few slides that I've shown during the research roundtable yesterday, and do me a favor, just bear with me. Yeah? So this one here shows you a scientific measure of gross motor development. This is the so-called GMFM66, which is basically a gross motor function measure. And at the x-axis, this is the patient's age, starts at 0, and in this little dot, it's 20 as the highest. And the y-axis is the score. It doesn't mean anything by itself, but you can roughly think about 100 is a typically developing adult, and 70 is the ability of someone who's basically walking but still has difficulties. I'm going to show you this because what we're trying to let our biopharma partners and our researchers know is that we're trying to think about where are our STXs on this chart. Yeah? And one concept that we're trying to kind of share with everybody is that we think about this in 3 different groups. Yeah? We know in our young kids with STXBP1, we see this dynamic phase. This is where kind of our STXs are gaining milestones. You know, they change every 6 months. They come back to us and we see that they've acquired new milestones and are kind of making progress. There's one point when we see that things are stable. Yeah? Those are kind of where we think about how can we change a baseline where patients don't really change that much from months to months, and this is something that we know as well. So as adults, we don't change in our motor skill or our cognitive skills. We're relatively set at a stable level. Yeah? And then at the same time, we know that STXBP1 has a very wide range. We know that there are some STXers that have very few skills, yeah, who kind of have a hard time achieving milestones, and we have some STXs that are extremely good. And this is important for like trial development, that we try to separate this out. What is typical? What is unusual? Yeah? What is an outlier? What is a typical STX development? And I'm just going to share this with you because those are these kind of concepts that we're trying to develop to make STX predictable. So I'm going to go even more scientific. I'm going to show you what we're doing every Wednesday at 2 p.m. when we're reviewing our data from the previous week in STAR. And this is what it looks like. We have a big screen, and then suddenly these kind of things pop up. So this, again, is a measure. Again, the x-axis, the horizontal is the age. The y-axis is a value, and this is for a gross motor score. Gross motor is walking, running, sitting, and you can see not just points here, but you can see lines. Yeah? And these lines are the different visits. I've pointed out 2 patients here. This little star is a patient who we've seen for the first time. It's the first data point. And then you see this kind of line there. This is one of our STXs who we've seen now 6 times. So what we want to move these points and make them spaghettis. Yeah? This is our goal for trial readiness, that we're not just kind of outlining where our patients are, but that we have lines and follow this through. This is now the second phase of STAR. We want you to come back. Yeah, we kind of said we expect that we're complete with this data collection in summer 2028, but until then, we don't want to take our foot off the gas pedal. We have to draw these spaghettis and make them more predictable. This is very important because we want to see how much change we see in our STXers. So I'm going to take this one now, and I'm going to show you something that I wanted to, that is a little bit inspired by what Bridget was sharing earlier. Bridget, I need your attention. So, and this is when we, what you guys have seen is that there's so much misunderstanding about STXBP1. And this is because when we see progress on STXBP1, it is not when we think it actually happens. So you can take these gross motor scores, you can take the same thing, and now map this onto what is called age equivalence. And this is here. So this is the same. The left and the middle one is the very same thing, but we're not looking at points. We're looking at how does this match to a child's age. So on the y-axis, we have like 20 months, 24 months, yeah? And what you see is how these values suddenly they spread out. So what is happening here is that at some point, our STXers making progress when other kids are already stable. Now you can see sometimes we have this growth that our STXers suddenly make a progress that we would think of like a 6 months difference or almost like 9 months difference. And they do this typically later than typically developing kids do this. We know this. We know walking in our STXers happens somewhere between 3.5 and 5 years. It's much, much later than we would see this in typical kids. Yeah? But it still happens. It just happens at a time when we wouldn't expect this. This is why STX is so perplexing, and this is why we see these kind of like, almost like horizontal bars there. Yeah? And then finally, what have we learned about variants? So variants are the genetic changes we see in STXBP1. And this is a big overview here of the different type of genetic changes that we see. So overall, and we're going to have some presentations about this later, overall we kind of think that STXBP1 is a condition that is due to what is called haploinsufficiency. Haploinsufficiency means you have a disease if one copy of a gene is missing. Yeah? We know this, that many STXers have mutations that break the gene. Yeah? But we also know that there are many so-called recurrent variants, so many variants that happen over and over again independently in our STXers. Yeah? Right now, there's quite a bit of research going on what these different variants do, but the overall theme is that they all do the same thing. They all lead to one copy of the gene not functioning well. And this is important because STXBP1 is a single disease. There are not different types of STX based on genetic changes. It is one common disease, and this is something that is currently being worked on very intensely. So I wanted to give you my clinical update in 2026. Thank you for listening to me. We talked about seizures, development, and then I eventually kind of give you a brief update on the STX variants. And I'm a little scared here for the next balloon popping, so I'm kind of...
We have a lot of drama this morning. The alarms, the balloons popping.
Yeah.
Exciting. Thank you, Ingo. We have time for a couple of questions, and we have a couple microphones in the room. Anna?
I'll run.
Oh, you're a runner. Oh, great. And we have a runner also. Does anyone have any questions for Ingo? All right, we have a question over here. Coming to you. Anyone over here?
My question is about seizures. I wanted to know if you found a higher likelihood of seizures to reoccur if the STXers had them in infancy, or if you've seen less of a reoccurrence as they get older if they did not have any in infancy.
Yeah, and if you don't mind, I'm going to quickly repeat this question because of our overall background noise here. So the question was, when we see seizures recurring in STXBP1, whether there's any pattern, whether this is more likely if seizures in STX had happened very, very early on. The answer is it's probably not related to this. Yeah. We have done some work initially trying to understand how do seizures in STXBP1 look like in the first year of life. So what happens? I can maybe go back here briefly. Can I get my presentation back? So we've looked very kind of in a very detailed way on how seizures look like in the first year of life, where we kind of really looked at every single week of patients who had seizures in the first year of life, because we wanted to understand, is there a relationship between having seizures as a newborn? Is there a relationship to having a higher likelihood of epileptic spasm? Is there a higher likelihood of having uncontrolled seizures later? You know? And the typical wisdom in the epilepsy field is if all of these is often true. You know, what we kind of often see in other conditions, when you have newborn seizures and you have spasms, you're more likely to have this later on. This is not true for STXBP1. So what we see in STXBP1 is almost like an unusual pattern, that we know the risk for having ongoing seizures is higher if you have seizures at the end of the first year of life, independent of what happened earlier. Yeah, so we have patients who have neonatal seizures and never have seizures again. We have patients who have infantile spasms that are very easily treated, and we have patients kind of where the seizures are starting later. This is a very perplexing pattern in STXBP1 that is unlike any other condition. Yeah? And the recurrence of seizures is not related to what happens in the first year of life.
Hello, sir.
Hi.
My name is Suhas. I think you know me personally. So thank you very much for your insightful study on the STXBP1. I appreciate the STAR study team
Thank you.
for giving such a wonderful data. So firstly, I want to ask, how do I see my kid in this chart? Is there a way that personally, like, I can see like how my kid is performing against all the other data that we have?
This one here, right? Yeah, I was actually waiting for this question. I was fishing for it. Yeah. So we haven't actually we haven't had a way to really kind of share this with families yet. We're thinking about this, what the best way would be to do this. But I think this is when I mentioned earlier about what the next phase of STAR is going to be once we have the data. Those are things that we would like to do. You know? It's on a one-on-one basis, it's often easy, but it's often very complicated to really kind of give reliable data back. You know? But those are some of the things we're thinking about. You know, this is about how we want to evolve our study. What do we do once our data collection is complete?
We have time for one more question.
Thank you for the presentation. I don't want to get emotional, but I would like to ask you. You mentioned about the walking between 3 and 5. So I would like to know if you have any data or something about reaching that goal after that age. I know this is unpredictable.
Yeah,
you already mentioned, but it's something that I can't stop thinking about it.
Yeah, no, I think so. This is maybe I'll take this question. If you don't mind, I'm going to rephrase this a little bit. Yeah, so when we think we have typical milestones, we know when our STXs achieve certain milestones. And I'm going to go back to this one here. This shows you basically the gray line here is of those who walk. We know that 90% walk by the age of 5. And of those who eventually walk, 10% walk later. Yeah? It is not necessarily predictable if you have not achieved this by the age of 5. And I think this is part that we would like to do in the natural history, just to kind of see how much change do we actually see. Yeah? In many cases, when people think about this in other conditions, let's say the cutoff, when someone tells you it's very unlikely to achieve independent walking happens much later. It's at the age of like 9 or 10. Yeah?
Thank you, Ingo.
Thank you.